Today, I'm tackling an important topic with relation to sepsis and patterns that I'm seeing around certainly the UK and now possibly in reference to this really important case with regards to Kyle Busch. It's important to recognize that when I talk about this case, I am only using information from social media. I don't have any inside information. However, I thought that it was important enough to talk about it in relation to patterns of disease presentation. What I hope you will understand by the end of this is that the way how sepsis is presenting seems to be different. And I think I have got enough statistics to back up my statements. It's not just made randomly. What you have to understand as well is that I have been arguing for a long time that there needs to be very detailed reanalysis of how disease presentation occurs when we compare the pre-pandemic to the post-pandemic period. And this case is an example of one that I think raises the point very clearly. Here is the story in case you don't know about it, and it's to do with Kyle Busch. He's a NASCAR champion and he died of pneumonia and sepsis. And this is from BBC News. And I'll go into a few more details about this because, as I said before, the relevance of it is that it is reflective of a pattern that I think is occurring more frequently than is actually being acknowledged. And when you look carefully, here is the story in some more detail. NASCAR champion Kyle Busch died after severe pneumonia progressed into sepsis. That's what the family had stated. They said the illness resulted in rapid and overwhelming associated complications. And he was clearly a very talented athlete. And you can't do these things if you are not fit and well. And so the fact that he had already won two Cup Series titles, 63 races, he was in the middle of the 22nd season of NASCAR's top division when he died. He was due to compete in a race this weekend. This is someone who is still at the peak of their talent. We must remember the family. He is survived by his parents, his wife, and his two young children. So this is still fundamentally a very sad story, but it has some important clinical details that I want to share with you with regards to what exactly happened. It seems that he had some symptoms that were present for a few days, or not a few days, probably a few weeks, a couple of weeks before this event happened. And when I look at the timeline, so about 1 to 2 weeks before, he had sinus cold with cough. And he was clearly okay enough to continue racing. But on one of the race weekends, his cough was persisting and he was seen by a doctor after the race. But clearly, he was still able to continue. So maybe he was given antibiotics. It's not clear. We don't have any history. Then by the 15th of May, still competing. So again, he has ongoing symptoms. 20th of May, short of breath, very hot, felt faint. He was coughing up some blood. By the 21st, he had severe pneumonia confirmed. He was septic and he died within a day or so. This is exceptionally unusual in a young person. It's not that young people don't die of sepsis, but the reality is that it's pretty rare. I'll let you understand the problem with sepsis is about the timeline. And so we tend to treat sepsis very, very seriously. Okay. And to understand a little bit about what happens with sepsis is that when you look at how it goes, one, the infection starts. And in his case, that was about 1 to 2 weeks before. Then the body overreacts. This is when they now go into full-blown sepsis. And what happens is that the immune system overreacts. It's almost not quite a cytokine storm, but the immune system overproduces cytokines. And then this causes the blood vessels to start leaking, and then they relax. When that happens, the blood pressure falls. When the blood pressure falls, you can't perfuse the organs, the brain, the heart, the kidneys. They all start to shut down. And if this is not addressed, a person could die. Those are the steps. Now, you may ask yourself, well, why would the body overreact in that way to an infection? And as I was thinking about different analogies, I guess the simplest analogy would be there is a small fire in a kitchen of an apartment building. The fire alarm goes off, and in that apartment building, they have sprinklers. The whole sprinkler system goes off to put out the fire, and it destroys everybody's furniture in the whole apartment building. Or if you understand, it's a response that occurs, and you can have inadvertent outcomes. That's technically what sepsis can be like. That's a simple analogy. Where it's very serious is when it hits this phase, when the blood vessels start leaking and relax. This is the hypotension. The blood pressure is usually very low, and this is where we're usually trying to reverse this. So a young patient who ends up with sepsis and ends up in hospital will very often be on intensive care. So we don't know the details of this, but I would almost guarantee that if he was alive by the time he reached hospital, he would have been on intensive care. He would have been given specific medication to try and keep his blood pressure up. We call them inotropes. And these medications try and help the blood pressure or the blood vessels to contract so that the blood pressure rises, and so you can have blood flowing to the essential organs. If you can't do that, that's when the organs start to shut down very quickly. And at that point, the damage is almost irreversible. And in a young, healthy, fit person, that probably sounds like what happened in order for him to die so quickly after a pneumonia. You have to remember, he was, I think, at the track. He was working on a car. Then he was found in the bathroom feeling very faint, coughing up blood, and that's when he went into hospital. So on the day in question, even though feeling unwell, he was still able to carry out his normal activities. So the deterioration was extremely quick. This is now where I shift in terms of my focus, because when I see these patterns happen, I start to ask, hold on, is this normal? Is this what we would expect? What is happening? Is this something else that is occurring that could be relevant? So now look carefully at this. Now, this is now where I went into the data and I started to try and understand exactly what may be going on in terms of sepsis. Now, I had access, or I have access to data points, 186 million data points. And so I am looking at 9 years of publicly available information, looking at hospital episode statistics to try and understand what is changing in the pandemic. A lot of people discount this kind of work. My problem is that they're not doing the proper epidemiology to understand why we are seeing very unusual presentations with regards to what's happening in hospital. Now, that's my anecdotal experience that I've been talking about for years, but the data that I'm seeing now indicates this is not anecdotal. It's not just me. It's just that nobody seems to be talking about it, or nobody realizes that this is a pattern. Because what I've been arguing is that people are now presenting with sepsis not like sepsis. When we think of the characteristics with people who are normally septic, their blood pressure goes down. They tend to have a fever because they've got an infection. Sometimes they can get quite confused. You can see changes in their blood works, and you recognize that this person needs to have antibiotics immediately within an hour of recognizing it. It kicks in a whole series of steps in hospitals to prevent or reduce the risk of this episode of septic shock. That's essentially what it's about. And this is why sepsis has been a big topic for many decades. Here's the problem. If people are no longer presenting in the same way, where they are coming into hospital with symptoms of an infection, but not necessarily clear sepsis, and it gets missed, what will be the outcomes? So, what I've then done is I have looked through data for 9 years to try and see if there's a pattern that could be relevant. So, as I said, this is not necessarily telling you what's happening. It's just me asking very specific questions about hospital admissions over 9 years. And what we're seeing here is that there are 4 key indicators that are changing in the pre-pandemic period to the post-pandemic period, 24-25. 1, recorded sepsis has gone down 23%. Now, if anybody's clinical here, they should know this is a red flag. Why would there be a 23% drop in the amount of patients who are ICD coded as sepsis? At the same time, we have an 80% dangerously low blood pressure compared to the pre-pandemic period. This is in 24-25. Heart failure has gone up, kidney injury has gone up, respiratory failure has gone up, pneumonia admissions have gone up. All of this is happening with recorded sepsis falling 23%. I'm just telling you, that makes no sense. Something is wrong. And this is what I'm arguing. And I'm hoping that clinical people are watching this because they need to know this is going on. I have a suspicion that because clinicians are not really talking about the challenges that are happening in the hospital environment, people are thinking that everything is just the same. No, and it is because I know what is happening why, when this case came up, I knew to take it seriously. Again, here is another chart looking at sepsis and severity codes. It's moving in opposite directions in terms of one of the critical markers of sepsis, hypotension, low blood pressure. Recorded sepsis, this is 2016, went up, was coming down somewhat. Then post-pandemic, this is the pandemic period, 2020, 2021, flattened, coming down, and at the same time, you have a divergence with regards to hypotension. As I said, sepsis, because hypotension is such a big part of the coding, we're seeing a 23% fall in that coding. So it means hospitals are not recognizing sepsis because people are still dying. This is the really important point. We may have to go back to our analysis and redo the research to say what else can be used to try and understand what really is going on with sepsis. As I said, again, this is from my chart. This one is all mine. So I can't say that this is from any major epidemiology association. I just happen to have the data and I can analyze it. And you can see here, hypotension is the highest rising one with heart failure, acute kidney injury, electrolyte disturbances, respiratory failure. All of them are going and rising at the same time as here, sepsis is falling. And SIRS, which is again a sepsis cause, definitely falling all the way down. There is a change in presentation, and we need to understand why. Now, for anyone who has been following me, they will know that I'm talking subtly about COVID, the changes to the immune response in people across the population. I have been raising awareness of this for at least 5 years because when we were doing our research, we saw some unusual patterns with regards to spike protein and how the immune system handles it. I think what we're starting to see now at a population level is a trajectory of disease that warrants very serious research. Now, there's another thing that I haven't yet said, and anyone who understands what I'm looking at will understand where I'm coming from. When I hear that he had a sinus infection and cough and so on 2 weeks before, and then ends up with sepsis 2 weeks after the onset of symptoms, in my mind, that first thing that pops into my mind is a COVID infection. At the moment, it is so subtle. So many people are having these random symptoms that they just think is another cold or something. But when we look down the line, we are getting some of the most complicated outcomes. And one of the things that I have said over and over whenever I talk to clinicians, don't underestimate looking for the prodrome. When you see a patient who is very unwell, look carefully to see if they had symptoms of what is likely to be a viral infection, sometimes 2 to 3 weeks before this major event. Now, we know that viral infections can have an impact on presentation down the line, but COVID seems to be doing this at a level we have never seen before. And so, without that understanding, we could very easily miss critical signals that need to be addressed. And again, here's another slide I built to show you this strange post-pandemic infection signal. Pneumonia, up 14%. But sepsis is down 23%. Organ stress, hypotension is up 80%. Heart failure, 51. Kidney disease, 20. Respiratory failure, 27. All of that could fit with sepsis that is not being seen. One of the critical things that we know clinically as well is that patients who have immune suppression, so if they were on chemotherapy or if they had recent radiotherapy or if they're on immune suppressive drugs, we know that sepsis doesn't present in a normal fashion. And so when those people present even with subtle symptoms, we very aggressively look for sepsis and treat it. Meaning, if you have a patient who has cancer, they've just had chemotherapy, they come into hospital with just a cough, little fever, they're looking okay, but their inflammatory markers are rising. Because you know they're immune suppressed, you don't take any chances, and very often they get on antibiotics. If it was just a normal person, you wouldn't do that. The problem is, what happens if the population is now presenting like patients who have had chemotherapy or are immune suppressed? That's when you will miss the signals, and then these patients turn up with severe sepsis, at which point the horse has already bolted. You're already trying to reverse the cytokine storm that occurs with the immune system, and it is very difficult to do. That seems to be the reality that we are facing. And I think one of the problems that we have is that listening to what had happened and looking carefully at what had happened with Kyle Busch, he fits that pattern. Poor indicators of sepsis, then a rapid collapse, with sadly death within a very short period of time. The challenge that we have now is how do we mitigate this? I understand what the psychological problems are. People don't want to look at the COVID pandemic anymore. Everybody wants to move on. I understand that. And that's something that is quite natural when we've been through a traumatic period. However, when it comes to science, science needs to be objective. It doesn't have narratives. It doesn't have psychological trauma. It looks beyond all of that and it tries to make sense of what is going on. The point that we can't get away from is the data. And the data tells us something is wrong. Sepsis is down, low blood pressure is up, heart failure is up, kidney injury is up, respiratory failure is up, pneumonia admissions are up, but this is down. It makes no sense. I don't want to say exactly what I'm thinking, but anyone who has followed me will probably know exactly what I'm thinking. I want us to look, prove me wrong, study it, see why it is different. But if we leave this, remember, this is not a moment in time. This is a trajectory. And this trajectory is continuing to rise. If we leave it, the outcomes in the long term could be horrific. That's the point that I want to make. And this is why we're making people aware of these things. Because I believe that whatever our views are, we need to study the data and make sure it makes sense. Thank you very much for listening. Look in the description if you want access to these pandemic dashboards. I am continuing to build all of them out because I think that this is very important information and you'll be one of the first to see and hear about it. Have a great evening.